Right. Welcome to our second installment of an educational series on peripheral nerve surgery, which is sponsored through the Education Committee of the AANS CNS Section on Disorders of Spine and Peripheral Nerves. My name is Jared Pasapia. I'm joined here with Dr. Elias Risk, and we're very pleased to welcome Dr. Kimberly Harbaugh as our guest for today. Dr. Harbaugh is a neurosurgeon at Penn State with a subspecialty interest in peripheral nerve surgery. She's done extensive cadaver and anatomic studies that have greatly contributed to our field, and we're very pleased to have her today. So thank you for joining us.
Thank you, Dr. Harbaugh.
Thank you.
All right, so for today, we'd like to discuss carpal tunnel, which is the most common peripheral nerve entrapment. And we just wanted to start out, Dr. Harbaugh, if you're seeing a patient in the office, what are some of the common clinical history that you would obtain?
It's pretty common for them to come in complaining of pain. Typically, the pain will be at the wrist region, but can radiate proximally, sometimes all the way to the shoulder. But it's key to make sure that any sensory symptoms that they have or weaknesses distal to the area where you think the compression is. And the compression is typically, in the carpal tunnel, underneath the transverse carpal ligament. The carpal bones form a wrist, the wrist bones form an arch, and then the transverse carpal ligament goes across. The finger flexors go through that tunnel along with the nerve. And so anything that causes compression of that area will give them symptoms. So unlike a cervical radiculopathy where the pain starts at the neck and runs down the arm, and the carpal tunnel patients will typically tell you they have this awful aching at the wrist. It's worse at night. They tend to shake their hand. They'll sometimes stick their hand in a bucket of water to try and make it feel better. They'll stretch it, things like that. Other things that make them, the history that I look for are they'll have worsening symptoms with driving, talking on the phone, things like that. Any repetitive motions will also kind of bring their symptoms on. There's numbness, they'll often describe it as the whole hand, but if you actually pin them down, you say, well, is your pinky involved as much as the rest of the hand? And they often will say, no, not so much that. And then again, if you're trying to sort out radiculopathy versus carpal tunnel, you want to ask them whether or not they have any numbness that goes proximal to the wrist. They'll say, oh, my symptoms go all the way up, but you want to sort out, is it numbness or is it pain?
Perfect. That's very comprehensive. And I agree, sometimes their symptoms may not appear as textbook and may involve other fingers or move more proximally. But as you said, when you really pin them down, it hopefully should be consistent. So in addition to some of the clinical findings, what are some of the physical exam things that you would look for?
I look for the hand. I look for weakness of the thenar muscles. And then so one of the things that you can do is have them hold their hands out like this and point their hands together and stick their thumbs out. And that allows you to really assess that thenar eminence. And for the abductor pollicis brevis muscle. You can check for the opponents as well. Sometimes people can cheat though with other finger flexors. So I find the abductor pollicis brevis to be the most useful muscle to test for carpal tunnel syndrome. The other thing you can test for is the lumbricals. Have them make a right angle like that, and then you're going to push on the finger to make sure they can keep the fingers out nice and straight. That's one of the little tricks for that. So that's for the motor exam. And then sensory exam, I usually test pinprick for the whole hand, front and back. I do both hands, and I usually do the feet too, because if someone has an early peripheral neuropathy, it'll show up in the lower extremities before it gets to the hands. So that's one of the things that I like to look for as well.
Well, great. That's a great pearl to check the lower extremities too.
Do you do any type of maneuvers like the Fallon test and Tinel or the Durkin signs?
Yep, exactly. Yeah, you tap on the nerve at the carpal tunnel, have them flex, extreme flexion or extreme extension should bring on worsening of the symptoms. And sometimes just by compressing the hand in that region, you can also bring on sensory symptoms in the median distribution.
For a patient that you see who has really the classic findings by history and physical exam, do you typically get any other diagnostic studies, or is that enough for you to move forward with potential surgical intervention?
A lot of people will operate just based on the clinical history and exam, and I don't think that's a wrong thing to do. I like getting the electrodiagnostic studies. We have a really good lab. In a certified lab, they'll give you the numbers and they'll give you the normal controls. And so that can help you kind of sort out what's happening. The reason I like them is because it confirms the diagnosis. And people talk about it ruling out other diagnoses, but in my experience, often people have additional diagnoses. It's not uncommon in a diabetic patient, for example, to have some neuropathy. That's why they are more likely to get the carpal tunnel in the first place. And so you can pin that out, and their overall results and prognosis is going to be different than someone who doesn't have peripheral neuropathy. So it helps include other diagnoses as well. Like so you could have a chronic cervical radiculopathy, some other findings. So I like to get those. It's also important because it gives you a baseline for those patients like the diabetics who you know are going to go on and have worsening peripheral neuropathy down the road, or someone who's got arthritis in the hand and chronic pain after the surgery. Those patients, it's nice to have a baseline so that when they come back, and you get a repeat, if they're having recurrent symptoms or persistent symptoms, you can repeat the EMG studies and have a baseline to look at. If the patient has a really severe carpal tunnel, the electrical numbers will look bad initially, and they get better, but they may not get back to normal. So if that person gets a repeat study, the overall report is just going to say carpal tunnel syndrome, and the patient is going to be wondering why they still have carpal tunnel if you just operated on them. So having that baseline study, I think, can be very, very important.
Yeah, that's a great point. I think cases where there's concern for recurrence, it can be very helpful to have any additional data. I also find it's very helpful to have the same person or same lab do the study where you can get some variations between.
Absolutely. Yeah. Yeah.
All right, great.
And I think it's important to get used to looking at the numbers, because if the report just says carpal tunnel, people tend to just take that at its face value. But just like we have people, look at our own MRI scans. We don't just rely on the radiologist to tell us what the brain looks like. And it's the same thing. If you're doing peripheral nerve a lot, you should get used to looking at the studies and having a sense of how they are.
Are there any kind of pearls for people that don't see nerve conduction studies or EMG as frequently in terms of for carpal tunnel, some of the numbers that you look for or the measurements?
Yeah, I think for those latencies there again, what you want to in our lab again, we have the normal values, and so that really helps a lot. But seeing a drop in the amplitude, you could check one side versus another. You want to see that if the latencies are like this one, the sensory latencies, if you start to get in that 5 level, that's definitely carpal tunnel syndrome. And often the amplitudes can start to drop a little bit as well. And then for patients where I'm looking at peripheral neuropathy, I want to also see whether or not the ulnar nerves look good, the radial looks good. Radial is very robust, so if people start to have trouble in the radial nerve, then that's definitely an indication that they may have a peripheral neuropathy.
Okay, excellent.
And they can have changes in just the sensory or the motor. So there's another study that they'll do where they'll look at the difference between the median and the ulnar at the hand. And if the difference is a half a millisecond or something like that, that counts. But to me, that's sort of cheating. If someone has really significant symptoms and they only have that subtle finding, I start to look for other causes or other diagnoses.
Okay, great.
And then on the EMG study, it's helpful because it gives you an idea of whether there's ongoing denervation or is it more chronic in nature. So for example, in this one here, you can see that you've got some spontaneous positive sharp waves. The recruitment is reduced in the abductor pollicis brevis on both hands. And so that's a sign of sort of a chronic change for the reduced recruitment pattern, but for the spontaneous activity, that's more ongoing. So sometimes you'll have a teacher come in and say, look, I don't have a break until Christmas. Can I just put this off? And if they have dramatic fibrillation changes or atrophy, I usually instruct them to kind of move ahead with surgery sooner rather than later.
That's great. And we talked a little bit about double crush, where perhaps you have cervical radiculopathy as well as a peripheral entrapment. Can you talk a little bit about more proximal median entrapment, something like pronator teres syndrome?
Yep. The pronator teres is a syndrome where the median nerve is compressed in the forearm area near the elbow. It can be compressed by the pronator teres is the most common place, but you could also get it under the arches of the flexor digitorum superficialis as well. Those are much less common, even than cervical radiculopathy, for example. In those cases, if you press on the forearm, often you'll have some discomfort there. Typically, the sensation in the palm is preserved, although in my experience, these patients have often already had their carpal tunnel, so then you don't know whether or not the arm is the sensory loss is because of the surgery or because of the trouble more proximally. And then so there's some provocative maneuvers where if they're trying to pronate against pressure, and some other tricks that you can check for that.
Great. Yeah, I find, as you mentioned, sometimes you can really get an exquisite, Tinel sign or a real tenderness to palpation at the proximal forearm over the entrapment.
And then, of course, the motor-wise, AIN, the anterior interosseous nerve, is often involved. And so those patients have a hard time flexing the tip of their thumb and flexing the tip of their index finger. So when you ask them to make a circle, they can't do that. They tend to have it more flat. And so that's that loss of the AOK sign. So that's a classic one. Anterior osteostosis syndrome can be spontaneous, and many of those cases are just an autoimmune type of thing. So if they just have the AIN type symptoms, you have to really go a little slower and make sure that you have a sense of compression before you take those folks to surgery. I'd usually give them a period of 3 to 6 months at least to see if they're going to improve before you jump in and decompress them.
Right, great. And so if we go back to diagnosis, we talked about electrical studies. Do you use MRI or ultrasound in your practice?
The ultrasound is becoming more and more common. We now have a electrophysiologist who is also trained in ultrasound, and she's very good. And we also are training the residents now to use the ultrasound. They're getting better at it. But for the formal measurements, we usually send them to our electrophysiologist. I don't use them as much, but if we're in cases where either the electrical studies are questionable or the history is just a little bit questionable, they can be very helpful as a confirming or excluding study. So I use them more selectively. I don't usually get MRI scans pre-op unless there's a situation where they've had prior surgery, and then I find them very helpful because the patients with either residual or recurrent symptoms, they can either have just generalized scarring around the nerve, or they can have a residual ligament. I think the next slide shows that in one of the patients that we had referred. So you can see on the top left-hand corner, there's an arrow there showing you that residual ligament. And then on the slide next to that, you can see that the ligament is there, and the nerve is squashed between that ligament and those tendons. And then you can also see the signal changes in the thenar muscle. And so that's showing you that they've got some active denervation. Yeah, and on those bottom slides with the proton density on the left-hand side, you can see the nerve roots kind of bulging out just by that ligament, and then the axials in that same area where, again, you've got that increased signal in the fascicles showing you that they're unhappy. And then on sagittal, you can see that residual ligament as well. And so for the post-op patients where they're having residual symptoms, if you're considering surgery knowing that the risk is higher, I think getting an MRI scan can be very helpful. Some people will use ultrasound in that setting as well. I like to have the static images that I can review right before the case, that sort of thing. I feel like I get more information out of it. I think the new generation who are using ultrasound on a regular basis probably would do just as well with the ultrasound.
Right. And so moving on from diagnosis now to treatment, can you talk a little bit about some non-surgical options first for carpal tunnel, such as bracing or injections?
Yep, I think first thing would be just kind of the typical non-steroidals. Give them a couple of weeks or a month or so of just round-the-clock routine non-steroidal anti-inflammatory agents. Have them use wrist splints at night. I think those could be very helpful. And injections, I don't tend to use those, but they can be very helpful. Some people, again, will get better with the injections and then don't necessarily need them, especially people with significant comorbidities. So you could try that in some patients. Make sure you send it to the person that you think does them really well. I don't do them myself, so you want to make sure you send them to somebody that you trust, because there is a potential for injury to the nerve. But they can be helpful, at least temporarily. Or if someone can't do surgery right now, but they're having a lot of miserable pain, you can potentially temporize. I think most of the studies show that both splinting and the steroid injections are useful more as a diagnostic measure than a permanent fix. So often those patients, if they do well with the splints initially, and then the splints stop working, or with an injection, there's a good chance that the carpal tunnel release will actually help those folks.
And if you go the route of non-operative management initially, about how long do you usually give patients? Is it something about 6 weeks, 3 months? What's your usual time course?
Yeah, it depends on how bad the EMG looks and how bad their clinical exam is, how miserable they are, that sort of thing. People who have a lot of symptoms, but the EMG looks pretty borderline, then I'm a little bit worried that they're not going to tolerate the normal pain from surgery, things like that. So those folks, I'll give them at least 6 weeks, maybe a couple of months. But if someone's got active denervation, I tend to be less, I usually use a shorter period of time, like, just a month or 2 or 6 weeks, like you said, for those folks. So it kind of depends in part on how bad the symptoms are, how sure I am of the carpal tunnel, and what their EMG looks like.
That makes sense. Yeah. And in someone, I think, who has severe atrophy, denervation changes, and refractory symptoms, kind of bypassing the splinting, I've done that in the past too, if it's very severe and really want to try to stop the progression.
Exactly.
All right, great. So moving on then to surgical treatment, would you be able to walk us through an open carpal tunnel, basically how you make the incision, any anatomic pearls?
Yep. You typically you want to go for that web space between the third and the fourth digits and come basically straight down. The other thing you can do is just kind of push the thenar and the hypothenar eminences together. You'll get that nice normal valley there, and that sort of gives you an idea of where it is. On the anatomical studies we did, the median nerve is almost always sort of right in midline as you get to the transverse carpal. I mean, as you get to the wrist crease there, the distal wrist crease. And so I generally make just a small incision right in the hand. I think the next slide shows some intra-op pictures. And so it doesn't have to be a very big incision. And I use just big enough to get the small Wheatlander in. I like that one. And then basically you're going to go straight down. I'll bipolar a little bit in the subacute tissues, but I try not to do any bipolaring once I get through the ligament, just could be concerns about the recurrent nerve and that sort of thing. If you have a bigger incision and you're using a retractor like that, you have to be a little bit careful because the recurrent branch of the median nerve comes up over the transverse carpal ligament distally and can often be kind of trapped in that. So if you retract too much, you theoretically could stretch that nerve and get them into trouble. So you got to be a little bit careful when you're retracting. I generally will split the mid portion of the ligament, and then I can lift it up either with a dental or a small mosquito. Mosquitoes are nice because you can open them up slightly, and then you can cut with your blade right over the top of that. I'll release distally out to the distal fat pad. If you look out, you can lift the soft tissues up and look straight out and see that distal fat pad. Once you see that, then you know you've decompressed distally. And then proximally, what I'll do is I'll relax the wrist a little bit, pull the skin up, and then you'll see the distal forearm fascian under direct vision. I generally will stand right at the fingers and go straight up the tunnel. And by relaxing the wrist a little bit, you let the nerve drop away, and so you're less likely to injure that as you're cutting that ligament. Then I generally just wash it out, make sure there's no bleeding, and just close with one or two at the most sub-Q stitches, absorbable stitches, just to be able to get the tension off the wound. And then I do a simple running stitch in the hand, as you can see in that bottom picture there. Generally, I have people come back at about 10 to 14 days for wound check and get the stitches out. I don't have them wear a splint or anything like that. For the surgery itself, we usually just use local anesthesia with some mild sedation. Some people just do local anesthesia alone. We generally don't use a tourniquet. And that's pretty much it.
Wonderful. Yeah, I think you covered a lot of the key pearls there. I think that's important, knowing distally, seeing fat as kind of your endpoint here. And typically in the wrist, you'll see kind of a sharp fall off of that fascia that's continuous along the forearm there. The closure, I think, is interesting. This is one where I've seen so much variety. What I've come to use now is just a single layer of 3/0 nylon in a horizontal mattress fashion. But I think putting lots of stitches in, I think probably is not as good. So for wound healing, but that's great. I think that covers all the surgical areas. One other question would be your thoughts on endoscopic surgery, if that's something that you've adopted or less so in your practice.
I haven't personally. I think it's a good technique. Again, it's somebody that if someone is insistent on having an endoscopic procedure, I make sure I send it to one of our guys that does them all the time. Because there is a much steeper learning curve. I think the two surgeries are basically equivalent. Some people think there's a little bit more. Most of the studies show there's a little bit more sensitivity of the scar for an open than an endoscopic. But some of the complications from endoscopic are a little bit higher from the standpoint of nerve injury, especially some of the sensory nerves. There's a communicating branch between the ulnar and the median sort of in the palm. So when they're coming back, they can get that. I've also seen potential transection of the nerve with the endoscopic, but that can happen with an open as well. And I think that's most commonly when you're coming across the wrist there, where the nerve can come up at an angle.
Okay, excellent.
So I think either one is fine. If it's something that you do and you do routinely, it's great. I just didn't feel like it was that much better that I would use it on a regular basis to get efficient at it. So I didn't, but I don't think there's anything wrong with the endoscopic approach.
Okay, great.
Efficiency in the OR too can be an effect because you do have to have a tourniquet, you have to have the endoscopic component. So you need several sets if you're doing several carpal tunnels a day. So it can be a strategic change in your flow as far as OR efficiency.
And some people require a tourniquet, which can be more uncomfortable for the patient. So they tend to have to be more heavily sedated to tolerate that. But it partly just depends on how efficient you are. If you're a quick surgeon and they've got a tourniquet on for 10 minutes, that may not be a big deal. But if you're taking a little bit longer, that can be uncomfortable for the patients as well.
Absolutely. All right. And I think just a final question, this series is really geared towards residents, medical students, junior faculty, for someone in that stage interested in a career in peripheral nerve surgery, any tips for them or recommendations as they go forward in training?
I think just if you can rotate, if you have a neurosurgeon who does peripheral nerve, I think that's awesome. And basically just getting interested in it. If you can help out in the anatomy lab, that really helps because you get used to seeing a lot of the anatomy you may not see as a neurosurgeon in training. So that can be helpful. Read the MRI scans whenever you can. I think that's also very, very helpful. And then, yeah, it's basically just going and doing it. And if you don't have a neurosurgeon, go hang out with the hand guys or some of the guys in your institution that do peripheral nerve. I think that's a really nice option for some people, and then you can build your own practice down the road.
I think the lab is extremely important, especially med school at cadaver labs. You get a lot of opportunity to do the sections and get comfortable with the nerves for sure. And I learned a lot from Dr. Harbaugh being in that situation. And then establishing a good relationship with your neurologist and radiologist is extremely important to figure out, and learn as you go and grow your fund of knowledge and having that relationship. And I saw some element of using the ultrasound because, they come in with some poor EMG sometimes.
Yes.
So the ultrasound sometimes can be, approved through insurance, and they typically, if you have a good relationship with your neurologist, they can redo the EMG for you as a diagnostic test to help you figure out that component. So having that relationship with the neurologist is extremely important to grow your relationship and learn from them because they have a lot of information that they can help with.
Yeah, I agree. That's great.
Well, a lot of great advice.
I have a couple of questions for you, Dr. Harbaugh, before we move. How do you address, for example, for somebody in clinical practice and a patient comes in with double carpal tunnel on each side? Like how do you manage to discuss this with a patient, both the dominant and non-dominant hand, and they, maybe it's a surgeon or somebody who's working constantly with their hands? How do you frame the treatment for that patient?
Typically, I'll try to talk them into staging it because, obviously you want them to not use that hand for at least the 2 weeks while you're waiting to get the stitches out. And so generally I'll stage it. I'll do the one hand initially, have them come back, make sure the wound's looking good. And then the next hand I'll do within a month or 6 weeks or so, get the second hand done. But I have had patients who wanted to have both done at the same time. Again, it takes a very dedicated caregiver who can help you with that. Because the worry is that if you release that transverse carpal ligament, you've now taken away the pulley. If your hand is flexed and you're trying to if your wrist is flexed and your fingers are flexed, you're going to bowstring those tendons out into the decompression. In those cases, post-op, I always tell patients, make sure if you have to grab things, you're grabbing something, a milk out of the refrigerator, cock your wrist back, so then you'll use your wrist bones as the pulley. And generally that works out fine. So having a dedicated person to help you just for the basic, toiletries and things like that is really important if you're going to do both hands at the same time. Typically, I just do the one and they'll have them come back, make sure that's healed up okay, and then do the second hand.
And the other question is the dreaded infection question. You've had so much experience and wisdom in that regard. So how do you address somebody who comes in with an infection, be it, simple, superficial, or a little bit more complicated where the skin edges are oozy and not easy to do a wound revision in those cases?
Yeah, that and fortunately I haven't had any major ones, but so initially that's why I like to see them back myself at like 10 days to make sure they're doing okay. And I tell them, if you're having troubles, call me sooner, because the key is, I think, getting them early. So having them not afraid to call you, even if it's 4 or 5 days. I generally have them leave their bandage on for 5 days and then take it off, and then come and see me again at 10 to 14 days. So the key is getting it early, because then you can get them started on antibiotics, just a routine, whatever, check your thing. But generally a Keflex or I like Bactrim, works really well because it kind of has a little bit broader coverage. But it sort of depends on your sensitivities at your institution, what looks good. But so generally catching it early is probably the key. I haven't had to take one back for a really bad infection. I'm not sure. But it can be very difficult because the nerve is right under the skin. So one of the tricks is to try to rotate some fat from the hypothenar region over that nerve and then try and close it back over that way. In some cases, you have to just leave it open to the and pack it until it gets healed up that way. What's your approach?
I've had one and a delayed presentation done elsewhere. And, looking at the wound, you can see the edges was like very wet and sloughing off. So I opted to just start IV antibiotics, broad spectrum, until, the wound healed a little bit better before I went back in and did the wound washout and revision. Because, it's like suturing wet paper tissue if you're, trying to keep things together. And there's not much leeway, as trying to, get undermining or trying to get that tissue to get closer together.
Yep.
The third question for you is, pillar pain after the decompression. How do you address that, and how do you, counsel your patients before surgery when you're talking to them about this?
Yeah, as we talked about, the arthritis of the basal joint is very common. It goes with it. I think the two go together. So when you release that tension band, you're now relaxing that carpal arch. So I always warn people ahead of time that you may have an increase in that pain at the wrist joint or aching pain at the wrist. Typically, I use non-steroidals. Most patients don't go to physical therapy, but for someone like that who's very uncomfortable, I'll often send them to physical therapy to help them work with them and make sure they're moving their fingers so that they don't get scar forming around the nerve. So those are the kind of the main things I use.
And then, have you seen in your long career, somebody who's had carpal tunnel release in their mid-30s, 40s, come back in with a recurrence of their, clinical presentation of carpal tunnel? How do you address those patients?
And yes, you do see that occasionally. It's not very common, but you can see it. The longer you're in practice, the more likely you'll see that. And in those patients, I think it's helpful to get an MRI scan because, again, 20 years later, they probably do have some arthritis. And so you're trying to sort out, is it really carpal tunnel or is it just the arthritis? So I'll often get an MRI scan in those folks and look for any residual compression or regrowth of the, it's that dense fascia in the hands. And it's typically the people who are really using their hands a lot. They're farmers, they're working around their house, that kind of thing. So MRI scan is what I do initially. Again, ultrasound probably will be the scan of choice in the future, but from my practice, I use an MRI scan.
That's great. Thank you.
I think in closing, we've talked about your work in the cadaver lab, and I think we have a great paper here to exemplify that. Would you like to say just a few words about the findings of this study?
Yeah, I had a patient, his picture's in that study, but who came in and he had clearly had a carpal tunnel with a release just in the palm, but he had a progressive neuroma in the nerve just proximal to that. And his nerve was on the scan was crossing over at an angle. And it made me realize that all of the anatomy books show the nerve coming straight into the carpal tunnel, and that's important if you're doing surgery and you're extending your instruments, whether it's endoscopic or open with the scissors across that region, and you expect the nerve to be straight up and down, you're unlikely to get it. So I occasionally, again, would have patients who would come in with a transected nerve, and I'm like, how do you transect the nerve if you're sending your instrument parallel? And I realized that the nerve's coming in at an angle in many cases, and in our study, only about 10% of the patients actually had a nerve that was coming parallel to the long axis of the forearm. Most of them had some angle, and some of them had a fairly fairly obtuse angle like this one here. So when the wrist is in a extended position, you've now trapped that nerve that's crossing over at an angle between the fascia and the underlying tendons. So for an endoscopic procedure where they typically rock the wrist back like that, there is a potential for you to potentially cut that nerve in half. My nerve crosses over at an angle like that, so that's one of the reasons why I was in tune to this. But at any rate, so that's why we now will relax the wrist, flex it a little bit when you're doing that maneuver where you're coming across to the wrist, so that even if the nerve is in the way, it'll kind of have the ability to sort of slide back and forth, and you're less likely to catch it.
I think most of the neuromas I've seen from injury was proximal, and the majority of recurrences or lack of decompression from the ligament is distal. Incomplete release. So I think you harped on two important pearls here for the resident students and educational component here. Thank you for sharing that.
Welcome.
All right. Well, thank you so much. That was a great session. We appreciate you joining us today.
Thank you so much. Have a great day.
Appreciate
Thank you.
It. Take care, guys. Thank you.